The GeriPal podcast is brought to you by Archstone Foundation, preparing society and meeting the needs of an aging population. And now, here are your hosts.
Welcome to the GeriPal podcast. This is Eric Guidera.
This is Alex Smith.
And Alex, we have two guests with us today.
First, we have Tim Farrell, who is Associate Professor in the Division of Geriatrics at the University of Utah School of Medicine. He is also the Vice Chair of the American Geriatrics Society Ethics Committee. Welcome to the GeriPal podcast, Tim.
Hey, thanks for having me, Alex and Eric.
And we are delighted to have a returning to us, Doug White, who is Vice Chair and Professor at the University of Pittsburgh School of Medicine. And I think this is something like your third time on our podcast. Welcome back, Doug.
Hi, thank you for having me.
So we're going to be talking about, again, resource allocation. We did this with Doug before. I encourage all of our listeners to listen to our first podcast around resource allocation. Today, we're going to specifically be talking about age-related considerations, including should age be part of a resource allocation framework. But before we get into that deep dive, Doug, Tim, do either of you have a song request?
I've got one. Could we do After Coronavirus Is Gone?
Okay.
Wait, which song is that?
This is a parody, right?
Yeah, it may have been written by a former member of the Eagles.
Yeah, so it says, I found the song online. Thank you for sending me the link. It's by Shred and Reagan in the Morning. So I have to attribute it to them. This will be interesting. Nobody on the road, nobody on the beach. A virus in the air, stay 6 feet out of reach. Empty shelves, empty streets, ordered to stay home. I got a makeshift mask, I made friends with a garden gnome. But I can't see you, and I'm not the only one sitting on your couch. Netflix is on, baby. I keep hoping this situation won't last long after coronavirus is gone.
That's wonderful.
Wait till you get to the end.
We should just have a podcast with coronavirus jokes too. That should be a future podcast right there.
I think that's the first parody song ever requested on GeriPal. So that's nice. I love it. I love the first, Tim.
Thank you, Tim.
You're welcome. Yeah, the second part is interesting, as you said.
Yeah.
So, how about so let's start off with the topic. Again, we're going to be talking about resource allocation and specifically like how does age fit into these frameworks? Because we're hearing from a lot of different places that maybe it does, or maybe it should, or maybe it shouldn't. But before we go into that, Tim, can I ask you, how did you get interested in this as a subject?
Yeah, when this all sort of started happening back in early March or so, I started noticing a lot of political leaders, popular press coming out with statements like, if we just, could almost segregate, isolate older adults, the rest of us could sort of go on with life as normal. And it got me thinking about this and looking into this a little bit further. And as I started talking with experts, people like Doug, finding out that actually it wasn't just at this sort of larger popular press level. It was really down into the weeds in terms of resource allocation frameworks if we ever needed to implement them, that older adults were disadvantaged. I thought, I need to look into this, educate myself about this, and then came to realize that really maybe there should be something, a definitive statement put out there about how we handle aging in the context of pandemics and resource allocation.
And as another important setup question here, Doug, we had you on the podcast early on. I think it was our second podcast about coronavirus, and we're now up to, this will be our 15th or 16th podcast. And we talked at that time about how we were worried that there was going to be a need to invoke these frameworks here in the United States. Have either of you or any of us heard of an institution in the U.S. that has invoked the framework, scarce allocation resource protocol, otherwise simply known as rationing?
Yeah, well, I think there are probably two questions to unpack there. One is rationing occurring? And then two, is it occurring in a systematic and an explicit way? And I think the answer to those two questions are different. We know pretty clearly from New York City and from some reports from individual hospitals that at least they've been rationing dialysis. And it's May 8th today, and there was just an article in the New York Times on that topic, that patients in ICUs who normally would be getting continuous renal replacement are getting half the dose. So, they're basically splitting the baby as the way to fix the shortage issue. But we also heard reports of patients in New York City in particular, them having to make really hard decisions around what kind of ventilator to give patients. And a lot of patients, young, healthy, old, frail patients also ended up on really substandard ventilators, which is a slightly different issue, but it was a rationing decision. As the last thing, I got a call 2 or 3 days ago from a hospital in Quito in Ecuador, where they said, we are already rationing beds and we're not doing it explicitly. We'd like to use the University of Pittsburgh model hospital policy.
Can I ask you, Doug, because I hear a lot about kind of when these resource allocation frameworks should come in, and that we should be doing a lot of mitigation before it happens.
Yeah.
What's rationing? What's mitigation? Like how should we think about that? Like I think about the CVVH, so this chronic, this critical illness. They're on these dialysis machines. You're seeing them split up. You get this one day, you don't get the other day. Is that just, good mitigation techniques to prevent a crisis, or is that rationing?
Yeah, it's rationing, I'd say, right? So rationing is the withholding of a potentially beneficial treatment on the grounds of scarcity. And I think if you look at CVVH and you say this is a continuous therapy, standard of care is that it's used continuously. We're using it for half of continuously, 12
part of the name, continuous.
Yes, right. Yeah. But mitigation, Eric, is a different thing. When people talk about mitigation, they're talking about doing whatever you can to increase resources or use them creatively in such a way that you don't have to compromise the standard of care.
Yeah.
The paradigmatic example is closing operating rooms to use them as intensive care units and use the ventilators, the operating room ventilators. That's mitigation. That's avoiding having to ration in a formal sense.
And then something like splitting a ventilator between two people, that's kind of right in there on the line, right? Because it's not really standard of care, and there's issues with that too. So
that's right. You're certainly, all we know now about splitting ventilators is that it's substandard. You only do it when you can't give it to everyone, and honestly, in my view, it's more of a psychological technique to avoid making hard decisions.
Mm-hmm. So if I could summarize, it seems like there are rationing decisions, or rationing is occurring, but they're not using a specific allocation framework in how in making these decisions. For example, around dialysis, and we had a similar experience. I'm talking with some colleagues in New York around this dialysis issue, and one nephrologist said, "We're giving it to everybody who asks for it. Means we're giving everybody crappy dialysis."
Yeah,
and so the question, I guess. It's occurring, but it's not going about in a thoughtful way. And I think what's underlying that, and Eric, you said at one point, nobody wants to be the first hospital to say that they're invoking the allocation framework. Nobody wants to say like, hey, we're rationing. We're the first people in the country to do it. We are rationing, and here's how we're choosing to ration, right? So in what sense is using this framework potentially an academic exercise, because nobody wants to do that. And as a result, they're just saying, hey, we're able to give it to everybody. Everybody's getting it. We're still giving dialysis to everybody. We had enough ventilators. Hooray.
Yeah, I was going to say, I think, though, at some point, you're going to have a system. And one of the things that we say very clearly in the position statement is that the reason to do this is to avoid ad hoc approaches and to give those frontline providers peace of mind is the right word, but that they should not be sort of in the position in the midst of managing these patients of sort of wrestling with the ethical issues. And that's where triage officers and triage committees and frameworks such as Doug's really come into play.
The thing about ad hoc, though, is it doesn't require the moral courage and leadership of administration to be the first to operationalize one of these frameworks. And I think, like Alex is saying, in the US, will anybody actually be that person, or will we continue to call things, we're not rationing, we're just giving half the people half the dose of CVVH? Doug, what do you think?
God, I mean, what's come out of New York State has been, in many ways, appalling. Tia Powell is a fantastic colleague and physician in New York State who headed up the New York State task force in 2015, I think, to develop allocation policies. They produced essentially a beautiful 300-page approach to allocating scarce resources. It was teed up and ready for the state to adopt, and they just refused to adopt any approach, knowing that any approach will be criticized, and no approach gives some sort of political cover to say, well, we didn't actually approve that. There's no blood on our hands.
Yeah. So all the responsibility falls on that, particular physician or nephrologist, and nobody in a leadership position. They can just say, oh, we didn't know.
Yeah, it's a total failure of leadership.
But also, I wonder if there are ways of reducing the barriers to invoking the allocation framework so that there are ways that hospitals, I don't know what the answers are, but is there a way we can meet somewhere in the middle where, this fear of being the first hospital to say that we're rationing is real. And you can understand the motivations behind the leadership in making those decisions, although we can, of course, criticize them. But are there ways that we can make it more palatable or acceptable to invoke the framework?
I'll ask Doug's thoughts about this. One of the things that we specifically target is that our position statement should be relevant not just to hospitals and health systems, but to policymakers at sort of the regional and national level. And so, in a sense, at the national level, they can provide some political cover, if you will. But I also understand the legalities involved and the difficulty of having, 50 different state legislatures and legal frameworks to go through. But if you can put it at a little higher, 30,000-foot level, and have a transparent, accountable process, that might ease some discomfort. I'm not sure what Doug's thoughts are.
I agree. Listen, these are not decisions for individual hospitals to make. At a minimum, it needs to be a region making the decision to say all of the hospitals in, for example, New York City or in a particular borough are swamped. We have to do this as a group. And that, that really calls on the notion that these are public health decisions, and the legitimate authority for those kind of decisions is the state.
Yeah. Okay. So I know we want to move on to the framework. We got to get to age, but I have one more critique about rationing nationally, and that is read a terrific tweet from David Grabowski, who we had on the podcast recently, who's a professor of health policy at Harvard, and his tweet was something like, half the deaths are in nursing homes, right? The outbreaks are exploding in nursing homes, and yet they're not getting half the attention in the press, and they're certainly not getting half of the PPE or the testing. And so, in a sense, we're rationing, and some of this is by age, right? Because who's in the nursing home? It's the older adults, and where we're allocating resources nationally. And those decisions are happening without any sort of, explicit thinking. It's just the train rolling the way that it's been rolling, right?
Well, I would just say there that one of the things that I've been thinking about recently is not even just the hospitals, but further up the supply chain. People that you might not otherwise think about who would be involved in these types of resource allocation frameworks are those who are supplying the resources. So thinking about this more broadly than just the end users, but those who are actually producing the equipment and sort of, these sort of ad hoc regional collaboratives that have sprung up to distribute resources. The fact that there's this allocation going across state lines, again, to me suggests that a broader coordinating framework might be more helpful and also just more livable and acceptable to the individual institutions.
Yeah, I agree. Also, I would just say, I think there are at least two things going on. One, we have this psychological this rescue imperative, the really intense psychological need to rescue those who appear to be dying in front of us. And Al Johnson, a San Francisco-based philosopher, did a lot of cool writing on the rule of rescue a long time ago. I think that's at play. It's the identifiable life is much more salient to us than the statistical life. But I don't think that's the whole story. I also think that this is just unmasking our bias toward the elderly and infirm in ways that, that they're not getting. They're not sort of getting to the forefront of policymakers' minds, and it's a real failing.
Mm-hmm. Yeah, this is perpetuating existing inequalities in our system, where nursing homes have been getting second shrift, lower tier resources, and then if you look at the press, it's largely negative, hammering nursing homes for being X star rating, whatever, in the press. So we should turn to the AGS framework, which we will have a link to in the show notes associated with this podcast on our post, as well as the companion article, which describes the ethical considerations that went into play in developing the framework. And Tim and Doug, both of you have developed these frameworks. Tim for AGS, leading the working group, and Doug for Pittsburgh. And my sense is they certainly agree far more than they disagree. In fact, I was rereading them this morning. I was like, wow, they are so remarkably similar. But Tim, could you walk us through in broad brushstrokes what the framework considers?
I'm happy to do that. And I think the most important thing is that when I was looking at these resource allocation frameworks and noticing that there were actually categorical exclusions, that certain people above age 90 just automatically don't pass go. You don't get the resource in question, would be excluded. We just say that is seems to be unfair, and that's our first recommendation, that you should not use age-based cutoffs in these frameworks. And I think the other there's 7 different recommendations, but just to highlight 2 additional ones. One would be the impact of social determinants in these calculations, which we've alluded to already. And a third would be, and I know Doug's an expert on this, would be considering the role of survival and how far out you go in terms of calculating a survival benefit, and sort of also considering the comorbidities in the equation. And the well-known frameworks and Doug's framework all include those considerations. We go into a little more detail on things like life years saved, long-term predicted life expectancy. We wax philosophical on some of the shortcomings of some of those approaches. But really, I think if you were to have one takeaway, it's do not use age-specific cutoffs. That's probably the take-home from the position statement.
Mm-hmm. So let's get into the age issue a little bit more. Your frameworks do not use age up front, I should say. You do consider age, and we'll get into that. But first, in a broader sense, which frameworks or states use age up front?
Well, I'll just begin, and maybe I'll hand the baton to Doug. I'll just start with my own state of Utah. Just looked at the framework. The updated framework has specific age cutoffs. Let's start there and hand it off to Doug.
Yeah, that's right. I mean, it's not just states, and there are several. I think Alabama was one as well. Professional societies put advanced age as an exclusion criterion, which is to say, if you're above whatever, and they didn't actually specify, but if you have quote unquote advanced age, you shouldn't even get into the queue for a ventilator. That's one. And then we saw recently in Italy, and just published the Italian Critical Care Society's recommendations. They were quite explicit about saying there should be age-based cutoffs.
Mm-hmm. And what are the ethics? So we talked about this a little bit, Doug, on our first podcast. What are the ethical underpinnings behind using age as a criteria? And we weigh these things differently. And your frameworks weigh it as a consideration that sort of comes in at the end. Whereas these other frameworks consider it as something that comes in at the beginning and can be even used as an exclusion, rather than making everybody part of the eligible pool, just at different priorities.
Yeah, exactly. I mean, the way that you use it and the reasons behind it are ethically matter, and legally, I think matter makes all the difference. So categorically excluding someone based on being 86, it's not clear the rationale. Maybe it's about prognosis, maybe not. Maybe it's about you've lived a full life. Maybe it's about you're not socially worthy. All those claims it's just uncertain unless it's really unpacked. But what we can all agree on is that it violates U.S. anti-discrimination law. Once you get beyond that, then there are a lot of other reasons that you might invoke age. So, if age was a perfect predictor of outcomes, if we had really good data that said, if you're above 90, that the survival rate is 0, that might be ethically relevant, but you would be using age as a proxy for prognosis rather than age in and of itself. And then I would say the third argument is what we call the life cycle based argument, which is it's almost counterintuitive in that it says that in some ways the elderly are the best off in the sense that they have had the most opportunities to get what we all hope for, which is the ability to live through life stages, to live a full life. And that in contrast, the young are the worst off. So this would be an approach to prioritizing the worst off in society. And I get that is not a clean analogy because there are lots of ways that the elderly in the moment might rightly be viewed to be the discriminated against, or in some ways certainly not the best off. But that's the logic of the fair innings or life cycle argument.
So fair innings. So we're somebody who has older adult, they've played 7 innings, they've made it that far, versus somebody who's younger, it's only played 4 innings, they still potentially have 5 more innings left. They certainly should get it over that other person.
And Alex, as I think we all know, sometimes the 8th and 9th innings can be the most exciting part of the ball game.
And in Little League, every kid gets to play. Every kid gets some innings.
Yeah, and you get a participation trophy at the end. How far away from the guidelines can we get into baseball?
No, I'm actually being serious. I think the Little League analogy is apt here, which is to say everyone gets some shot.
Right.
The worst off is the little kid at the very end of the bench, and he or she gets played.
But isn't there something to that? I remember there was some qualitative studies looking at what do people actually think is fair. I think based on that from the Maryland, I think information is that most people thought using age as exclusion was bad, but that there was something to fair innings. There was something to this idea that at least in these focus groups, that they felt like maybe that was a good thing for later on in the process, like a tiebreaker.
Exactly.
Yeah.
Exactly. This is, the Hopkins Maryland group that led by Lee Daugherty-Biddison and Ruth Faden did an amazing job. They did what's called deliberative democracy, which they engaged more than 300 community members in Maryland and took them through multiple half-day-long engagements where they really put these issues to them, gave them reading in advance, gave them expert consultation in the moment, engaged them in small group discussion, and then surveyed their opinions at the end. And what they found is that most people didn't think age should be a primary criterion, but roughly 70% said that on balance, when there are circumstances in which not everyone can get a resource, there should be some times when the younger person gets some priority.
And I would just add that taking a slightly different context, if we're talking about new therapies for COVID or immunizations, it may be the older adults get prioritized differently or more or highly than other groups. So we can invert this potentially and sort of use similar arguments. But I think that's certainly clear from the community engagement work.
It's a really good point, what Tim just raised. This notion that there might be certain circumstances in which you use age or really any other criterion, some medical decision, but it might be just the reverse in others. So, for example, it may be that the older adults will get priority for medications and vaccines because they're the most likely to benefit from them. I think that illustrates that we need to take a fairly nuanced approach to how we think about allocation, such that you can't make one framework and then it applies to everything.
I got another question. We are seeing, when you look at mortality rates for COVID, we see like it just starts going up at the age of 50 and it goes up and up with every other decade. So obviously those who are much older, 80s or 90s, their risk of dying from this so much higher than those who are in their 30s or 40s. So should age like play a role from a prognosis standpoint? And is there, I'm going to stop there and ask that question.
And I'll just say one of the things that we talk about in the position statement is sort of the difficulty in prognostication. I think the three of you are the experts here in prognostication, but certainly long-term prognostication gets difficult. Short-term / near-term, I know we can talk about the nuances there, probably a little bit more comfortable, or at least for clinicians. And so I think that's one branch point, if you will. Are you talking about short versus long-term? I think that's critical.
Yeah. And Eric, the way you framed the question was around COVID. It may be that COVID is a particular disease where age is particularly good in terms of correlating with prognosis. But just to sort of take a step back and think about making system level or policy level decisions, age, I mean, you two more than anyone know that age in and of itself as a predictor of all comers in illness is a pretty poor prognosticator. So I think it's much more important to look at it through that lens rather than through the narrow lens of COVID, because it will only be 50% of patients in an ICU that have COVID.
Yeah, that 60-year-old in your ICU actually may have a worse prognosis than that 80-year-old, depending on kind of what they came in with. I got another question. Go ahead, Tim.
I was going to say, we talk about also incorporating new information in deliberations of triage committees. And I think as we learn more about COVID, we'll have better information. Actually, I went online today and looked at the SOFA score, and there was a little yes or no button for, does your patient have COVID or not? And I thought, this is interesting. The SOFA folks are starting to, actually take this into account. So I think we'll have more refined prognostic models with COVID over time.
All right. I'm going back to New England Journal, Zeke Manual. I love him or hate him. Just use life expectancy. Like we should just be using that. We're trying to save the most lives, most life years. Should we be using life years, life expectancy when we're thinking about this? Which is, age is an important marker for that.
Well, I think Emmanuel strikes more of a utilitarian tone. And I think what we are saying in the position statement is that's really more of an aggregate measure, and really, I think, glosses over some of the individual factors in terms of prognostication. And so we come down on the side of more of that individual assessment, which is why we come out and say that we don't think that life years saved should be part of a resource allocation framework.
Yeah, here's the example that I find really compelling. It's a thought experiment, but say there are two people, twins, whatever, separated at birth. One lives a socially advantaged life. The other does not, ends up in sort of the worst social circumstances, lives in poverty, in a food desert, with poor access to healthcare. Those two with identical genetics, say that they're 50, the socially advantaged one is 50 and healthy and has 40 years of life left. The 50-year-old twin who lived in poverty may have 7 years left. And so if you really looked at life expectancy only, you'd prioritize the 50-year-old who was socially advantaged over the one who was disadvantaged. And I think many of us look at that and say, that's not okay.
Well, there's other calls out there. So maybe advocating for that we should give extra or minus points, or I guess it depends on your framework that you're using, to give those socially disadvantaged people more favorable numbers in a framework if they grew up or they're living in a zip code that is more socially disadvantaged, or if they have other markers of that. What do you guys think about that?
Yeah, I think it's a really important idea, and I would offer two things. One, we've tried to do that in crude ways in the University of Pittsburgh model policy, in the sense that we treat as equal people who have 5 years left to live and people who have 50. That's a way to try to level the playing field of social inequalities. The other is that You might have seen that there are some systems that give some priority to healthcare workers, which turns out to be a fairly white group of people. We expanded that to say it should be all essential workers. And that starts to cut across a much broader racial and socioeconomic demographic, grocery store workers, delivery truck drivers, maintenance crews. And so I think that's another way. And then the third thing I would say is that we're working with a group of economists at MIT that have put together an allocation strategy that uses something called categorical reserves, where you can actually preferentially prioritize individuals based on social disadvantage in a way that may actually affirmatively redress some of these things. It raises certainly big political questions about how should affirmative action rather than neutralization of problems come into play. But it's at least worth, I think, exploring the feasibility of it.
I was going to say that the area deprivation index certainly is powerful. I would also say it's not even just adding in these factors, but how you weight those factors. And I think that's going to be critical to explore. So I don't have the answers, but I think like Doug said, I think it's worth exploring.
I guess the other question is, so there's people coming together, thinking about this, putting together these frameworks, and then there's like the boots on the ground when you try to actually sandbox it, try to play it out in your ICU, even if you're not in crisis. How are you actually going to practically do it? So like the essential worker part, how do you actually know if somebody is an essential worker? Like Elon Musk is now making ventilators. Now he's an essential worker. I worry that, well-educated people are going to be very good at figuring out how they're all of a sudden an essential worker, versus those who may not be savvy enough in the medical system to declare themselves an essential worker. Yeah. The other worry I have with like healthcare providers is that, the only way you really know is if they work in your hospital system. Now we're biasing just, people who work with us to get these ventilators. And
a couple thoughts. I agree. This is a harder to specify thing. However, each state has and there's a federal list of essential employees or essential professions. So you can appeal to a state authorized list of jobs. And we actually do a reasonable job of figuring out what our patients do in terms of their social and occupational history. So it's not infeasible to do that. That's the first thing I would say. Maybe I'll leave it there.
I was going to add to that. My concern with this would be that we sort of forget about the invisible workforce of caregivers. I think they are essential and already are overlooked. And so thinking about that large workforce, actually, who are probably helping the social isolate and reduce the transmission of COVID really should also be prioritized. But it all comes down to what you think the definition of essential means. That's where it really is important to consider.
I would just say I think that we should push on this though, because it is a way to some degree affirmatively redress social inequalities. When you look at the list of essential workers, the vast majority are not white collar jobs.
Right, meatpacking workers. So it makes you wonder in some ways, like what are the motivations behind this? Who gets put on there? Of course, some of it will be political when we're talking about a state list or a federal list. And some of them will be for reasons that may not make as much sense. Meatpacking workers is a very diverse group, by the way. But my concern is that Trump added them to the list of essential workers because he didn't want meatpacking shortages. He wanted to protect businesses who wanted to keep those workers coming in. And potentially because he doesn't value the lives of those people who work in the meatpacking industry as much as he might value other lives. That is a controversial statement, but I'm going to make it anyway.
All the more reason to redress that.
Right. Last question for me is about the evolution. And I remember on your last podcast, Doug, you talked about how you changed your thinking around instrumental value. And I know that this, we were just talking about socioeconomic factors. And we have another podcast we did with Kirsten Bibbins-Domingo, who's arguing they should be incorporated in a greater extent in our bedside decision-making. And Harold Schmidt, we should thank, who published this. He's a doctor at University of Pennsylvania, published an article about this in the New York Times. And I can see the right at the top says, update, after this essay was published, the model guidance, linked to Doug's Pittsburgh guidelines, for rationing ventilators was revised. I'm interested in both of your thoughts and how your thinking has evolved over time and throughout the course of the pandemic, and what sort of pushback you've gotten from different groups and how you've responded to that.
Well, I mean, for me, this has been an evolution over the last decade. If you really go back and look at the first framework that we put together, which was much more conceptual, we talked about life expectancy writ large, and we put that on equal footing with life cycle. And if you look at the framework now, you see that neither of those are there in the same way. And I would say that this work of specifying and engaging the public and refining based on feedback is critically important. I wish that I could get it right the first time, but that's just not really, at least for me, that's not feasible. What I think is important is that we go through this reflective process where we have an initial idea, we bounce test it with the public, we engage policymakers and scholars, legal scholars too, to say, now, how does this fit with civil rights law? We get the perspectives of other people like Harold Schmidt, and we refine things. I would say that a small point, that we had revised the framework before Schmidt's article, and we revised it further because of the things that he misunderstood about the framework. We had already done away with using anything like long-term life expectancy and really focusing on near-term prognosis. So we felt we had to make that even more clear. Be that as it may, the work is in going through this process of what philosophers call wide reflective equilibrium and trying to figure out, when we have these competing goals of equality and actual medical effectiveness, how do we balance them when in some ways they're simply incommensurable? And that's a hard process.
One of the most important edits I think I made to one of the final drafts of the position statement was adding to the title the words COVID-19 era and beyond, because I think if we look too narrowly at the current time, we're just going to miss these opportunities for reflection. And we argue, we make some post-pandemic recommendations, including regular, review of these frameworks and resource strategies. So we can't be standing still. And maybe we'll be coming out with a revised statement in another 6 months or a year. So I think we all need to be, as Doug said, have this reflective equilibrium and take new information to account to get better with these frameworks.
Doug, Tim, I want to thank you both for joining us today. I think that, both of you have done amazing jobs in putting this together. Really love, Tim. I think the idea of, and I think for the AGS statement, just not using age as an exclusion is an important thing to highlight, because we're seeing it out there. We saw it in Italy. We're seeing it in other countries. And I think the other important thing too is that it certainly feels like, at least here in the Bay Area, we're past that surge for now, that we're not going to be using these frameworks. However, come fall, or 5 years down the line, if something else comes up, it's important to have. And Doug, as always, it's amazing to have you on this podcast.
Oh, thanks. It's fun. You guys are awesome. It's fun to be on.
Thanks for having us.
Speaking of fun, Alex, you want to do a little bit more of that parody song?
Just remember, you requested this, Tim. Out on the store today, I saw a cotton and a double roll multi-pack. I can't believe I found it. I'm just happy I can clean my crack. Time to take my temperature, hoping that it's low. I wanna go surfing now, but they won't let me go. I can't see you, I know this really isn't fun. I might need Prozac, no baseball on, baby. I can't tell you I won't stop drinking all day long after coronavirus is gone.
Well done.
I think that reaches a new low for lowbrow for our podcast.
Actually, initially suggested just the Don Henley version. So,
Tim, thank you very much for joining us.
Thank you for having me. It was a lot of fun. Thank you.
Big thank you too.
Thank you so much.
Thanks, guys.
Thank you to Archstone Foundation, and thank you to our listeners. And if you're listening to this, please like our podcast on whatever platform you're listening on.
And with that, stay safe, everybody.